as I say, we are kind of looking at harnessing technology in a low resource setting for greater impact on health. So Mackenzie, it's sort of the other end of your spectrum. So I want to start with a fairly broad question, particularly as we've gone through a big period of reflection leading up to this. And I'd like, in everyone's opinion, we can go around the table or chairs, what's been the most important development in the world of health tech in the last 12 months? And I asked the question about importance, not the biggest or the most well-known, but in your view, what is the most important? So would you like to start us off?
Yeah, I'll start.
Here we are.
I'm absolutely no expert on technology, so I couldn't define what's happened in the last 12 months, But I think that what we've noticed from a non-profit perspective is really this rise on social entrepreneurism and digital startups, and actually that focus on social good, which is definitely something that's been growing for a while, but that momentum is really continuing, and it's very exciting.
Well, I'm the opposite in that I don't know anything about health, so maybe I'll try and talk more about tech. I actually think this week the metadata retention law actually became law, and I think that has started to stimulate some conversations about privacy that are quite interesting in Australia. And so I wonder, maybe this is in leading up in the last 12 months, and maybe we'll see it in the next 12 months, the way that people start to think more and more about privacy and what that means for them in an age where so many large organisations, not looking anywhere in particular, know a lot about you, and you may or may not know that, or even how much they know. So I think that's a really interesting thing that's happening.
An interesting test. How many people in this room know that the Australian government gives them an individual healthcare identifier for every Australian citizen? So about half of you don't know that.
How do you actually use it?
And we're investigating, or not we, they are investigating an opt-out medical record for Australia at the moment. But from my point of view, it's interesting, you talk about it's the other end of the spectrum, but I think the same issues apply in both developed and undeveloped countries. To me, the biggest opportunity in the last 12 months has been the growth and interest in wearable and carryable technology, particularly carryable mobile phones. The third world may be poor, but mobile technology is very ubiquitous around there, and I don't mean just Fitbits and Ruffalo t-shirts for the worried well. What's it going to do for ageing? What's it going to do for disability? What's it going to do for the vulnerable? Someone developing smart apps that are doing that is where I want to see things go.
Kind of took mine, thank you. Yeah, I think one of the coolest wearables I've seen most recently is the Google venture where they're doing contact lenses that you can wear that'll do blood sampling. So if you have diabetes, you don't have to prick yourself every single day to find out what's happening. Stuff like that's really cool, interesting, and really changing the landscape for healthcare.
Well, I really have nothing to do with healthcare, so I'm a funny guest on this panel, but I will say, I notice a lot how people's behavior is, and I live in New York City, and one thing I often notice is riding the subways, how almost every single person on the train will be staring at a phone, and usually not really communicating with other humans on the train. And I just notice a lot of the ways in which the software programs that we're all using and the apps and the products that we're all using are having this kind of drug-like effect on us and on our psychologies. And we often think about medicine as something that you take in like a capsule form and swallow, and then it acts on your body from within. But if you broaden the notion of what medicine is, I think we could really also think of software as a kind of medicine in its capacity to transform our behavior. And so that's one of the frames that I use a lot to think is what are the drug-like effects that technologies are having on all of our minds nowadays? And can we design those effects to be more nourishing than addictive or anxiety-inducing? So I would say that's a frame that I would offer.
Well, that actually segues quite well to this next question. So the prevalence of technology in the build, you mentioned scale quite a lot. Obviously, in tech world, you start small and scale out. I was wondering, and we might actually start at this end, is what are the opportunities and also conversely the risks for developing health tech products in Australia or other first world markets, and then actually introducing them to low resource settings who may not be as comfortable in that sort of tech world?
Sure. Well, one thing I would offer for that is, we have this strange dynamic now where there's a very small and relatively homogeneous set of human minds that are creating a lot of these software platforms and idioms that are being exported en masse to the rest of the world. Specifically, they tend to be like large. I mean, look at this panel. We're like all guys, and there's one woman here. We're all within a certain age range. We're all white. There's a certain kind of worldview bias that's built into Silicon Valley in particular, and that ideology has been exported around to other countries for those who work in tech. Cultural contexts make such a big difference, and there's a very particular cultural context that's present for the people who design a lot of these tools, and then that cultural context is being exported around the world, and sometimes in really awkward ways. So I think there are some challenges there, and maybe better to go into these situations and see what's actually called for and what's actually needed, rather than just assuming that what works in California will work everywhere else.
I might just give an example of that. Macquarie University School of Health Informatics has a student who's doing some work in Bangladesh with mobile technology. Everyone in the poorest village has access to mobile technology. The problem is they don't have the literacy to text. And so it seriously limited the opportunity there. So it's just something they hadn't really thought about before. So now they're looking, what can we do that's more visual in that space.
I might add a story to that. I think there's probably a pretty valuable distinction between the way that some of the back-end technology is built and the way that some of the thinking is done, and maybe the channel with which people access that technology. So I would give the example, our Say is a project around civic engagement. The first version is based around a website. You get online, you vote, you ask questions. It's very much the white male mid-20s way of designing a brand new system is let's build a website. We did some work in India and lots of phones, not many smartphones, but we found a great way to engage with that community was to use message recording. So you could ring up, and because of the illiteracy problem, you could ring up and say, my question is to this politician, and it is that why aren't the potholes in the road fixed already, because we've been talking about this for the last 3 years. It was targeted, there was a lot of community support around that, but the smarts around how we were engaging with the leader and the voting stuff and all this kind of stuff and all the back end still existed. It's just that the channel to interact with that was modified to be more relevant to the particular user in that situation. So I think you do need to be, it's valuable to look at the two sides of that and not throw out the baby with the bathwater.
I'd just like to add in support of that. I think the real problem that we face is that actually the problems are being defined and solved not by the people themselves who are actually living within that. That's the whole sort of thing I would imagine that techs are looking at about the user experience and actually involving the users directly and not actually prescribing what their problem is, actually getting them to engage and say, this is the problem that we have, how can you come and help us generate a solution? I think that's the primary problem. We've got lots of great ideas, but they don't actually match to what people perceive as their own health problem. And the second one that we know and we face a lot of is about logistics. How do we actually get this technology out to where people need it? Those logistical and distribution channels don't actually exist. Often as well, ministries of health or other partners have defined contracts already in existence for a long-term period that are difficult to break, so they're not interested in actually incorporating that technology, even though that's going to result in them, having savings. They're locked into really high-cost contracts. So I think it's locally owned, generated problems and solutions, and also somehow being able to break through that actual distribution channel. So
I guess on that, when you look at governments, particularly in smaller countries, I mean, you would know more about those than the rest of us. When we look at government versus private enterprise, what are the risks there with collaboration, and do they need to exist together to actually break the current models? Can they exist together? What needs to change for that? The world of development that kind of sits up here to get into those environments.
It really depends on the context, I think. I think every government and private enterprise has a different sort of approach and response. I think the ones where I've seen that work the best is around where there's a real transparency about what each party's wanting to do. That creates a really good environment to actually building and cooperating and working together. And on the one, I would say Google's been very good about that, where they've actually set aside funds for non-profits to generate tech solutions and actually done that on the proviso that the output's actually put in the public domain.
I think there's a good example of that happening at the moment. There's a technology called FHIR, which stands for Fast Health Interoperability Resources, developed by a guy in Melbourne, but actually being pushed by Obama in the US at the moment because this is Connect. Interoperability is everything here, and it is about developing a set of resources that are web-based, open-sourced, anyone can grab that says, here are the bunch of templates, here's the bunch of definitions, here's the bunch of tools. You can build your app bottom up using this and it'll be able to talk to anything else that does that. A huge advantage is because, I have to say, by groups like HL7 who control this in the US, very nervous about it because it is open source, but a huge opportunity, particularly for developing countries, to be able to go and grab that stuff and use it. And that, to me, that's a good example of government saying, this is the need. You guys go out there, get your community together and make it work, because the private sector is much more agile and innovative. Government's not the place to do that.
Next question.
Oh, you've been a bit quiet there. I thought you might want to jump in.
Waiting for my opportunity.
Well, we can talk about data. That's your little background there. I think, so as you say, everyone does jump on the term big data. There's so much information there that I think a lot of people don't know what to do with yet, but there's also a lot of techs and developers and that kind of cohort who are starting to really learn data analysis and interpretation. So what is that ability and how does that actually allow us to apply data analysis in low resource settings in collaboration with those people who are on the ground? How might that work together, and can you give a specific example of something that's either working or not working in the current environment?
So the problem is that I hate the term big data.
Small data?
I think we tout tiny data. We think it's way more fascinating to look at an individual member and everything related to it. You look at big data, it's just tiny data multiplied up. It's not any more complex, it's just more of it. And so sure, you can find patterns and correlations, but honestly, breaking down to a really small thing to look at is way more fascinating to us. I don't know enough about those environments, about what we can find pattern-wise, so maybe someone else has more to talk about, but tiny data rules.
I can certainly talk about the pattern stuff. One of the things we're doing in Victoria at the moment, at the VCCC, the Victorian Comprehensive Cancer Centre, they're using IBM Watson to do analysis over a whole lot of things to try and draw some sort of inferences, comparing what they're doing at the University of Texas. Interesting in that, and we were having a discussion just beforehand, IBM's now said anyone can take Watson. It's free. You can go and play with it. I had a friend who played with it last weekend with some data. I don't think the incentive is altruism. They're trying to establish the value proposition and create a market. But again, it's those sorts of technologies. People these days don't have to have things like Hadoop and other technologies. You don't need to build a $30 million data warehouse to start doing the analytics. There's lots of information out in the operational stores. My big thing, I actually like metadata, not about people, but about data. Trying to assemble all this stuff from lots of different places is a real challenge, because you might be interested to know there are 27 different categories of sex in use in hospitals in Australia.
Wow. Wow, that's totally thrown what I was going to say. It's just blown my mind. I think, kind of to your point earlier, one of the challenges with low resource environments is not always the low resourceness, but actually the combination of the domain knowledge and the problem knowledge. And so you might have a bunch of big or little data people in Silicon Valley or in Australia or in any other kind of high resource environments, and a whole lot of people who know all about what's wrong with the roads or the health system in some small village in India or Africa or anywhere in the world. But how we bring those people together? Because I think unless you've got those people in the same room and both bring it, a bit like you and I, you start off saying, well, I don't know anything about tech and I don't know anything about health, so we should have a coffee and we can talk about tech and health and see if we can come up with some answers for next year or something. I think that's really crucial, is how do you get those people in the same room figuring out those problems together rather than separately?
Actually just reminded me that The keynote speaker last night, is it Helen, mentioned that one of the biggest problems is the data just doesn't even exist in these regions, right? I mean, if it's all paper and pencil, then what are you going to do? And that's probably the biggest challenge to begin with, is what metrics you're pulling in and how you're going to gather that data.
So then what are the ethical and confidentiality issues that surround that, particularly as, you know, we're working with data over here, but there might be ethical issues, whether it's America or in Asia Pacific, that we have to be aware of. So what are the implications, I guess, of that approach from an ethical point of view?
I'd be interested to know how you guys have dealt with that problem.
Sorry, I missed the first part of the question. It was about the privacy side.
Just about privacy and the ethical considerations of that collection.
So that's interesting, right? I don't want to say you have to convince people, but you have to show people the benefit of why that data is being collected and that's used for good. I think the more transparent you are about how that data is being applied, the more receptive they'll be to actually giving that up. You know, you look at like the step tracking reimbursement from Oscar, all it's doing is how much you're walking every day. Some people were a little, you know, they didn't want to actually give up that information, but you can't really tell that much about a person just from that piece of data. So it comes down to like a personal preference. Most of our members do accept it because again, they see that I get an incentive back, I'm healthier, this is a benefit, great. There's a reward for me. But if you're just collecting data and you don't know what it's being used for or how it's being applied, that's terrifying. I would never do that myself.
I think there's a real challenge in the incentives you give and the way that it interacts with where people are at in their lives too. I mean, we all give so much data to the Facebooks and Twitters of the world, and we have no problem with that whatsoever because of the thing we get back out of it, you know, the social interaction and all those other kinds of things. In your situation, people are giving you step data and they get dollars. Right? But for those incentives, there are always situations where incentives can be the wrong incentive for a person for where they're at in their life at their time, and that can be a negative thing for them. And so there's a really interesting ethical conundrum there about, well, if you blanket offer any incentive, whether it's money or any other kind of incentive, how are you making sure that, especially in a health environment, you're still doing no harm through offering those incentives?
Of the 2.5 million people who've opted in to have a personally controlled electronic health record, 1 in 200 of them have put restrictions on who can see it. That's because they've opted in, so they see it as important. If you go to the general population, it'll be less, but it does come down to choice. The Victorian Privacy Commissioner has said quite publicly, privacy shouldn't be used as a reason not to share health information. There's an international human right to health and wellbeing, there's an international human right to privacy. It's about designing a process by which you accommodate both. That's a challenge, but it's one worth following.
Yeah, we're living in a funny time with data, big data. For me, the most interesting question around big data is what can it not show us? In other words, what are we missing by thinking that data can tell us everything? I really see big data as becoming a new kind of religion for atheists. It's like this thing outside of ourselves that we think we can put faith in and that will tell us with absolute certainty how to behave in any kind of situation, whether we're a politician knowing what kind of votes to cast, or a scientist knowing what kind of things to study, or a teacher knowing what kind of topics to teach. I mean, you name it, like any domain of our society now, we are just surrendering our human agency and autonomy to data, which is going to tell us what to do. And what is lost in that process? I'm actually reminded of the Einstein quote, which is, not everything that counts can be counted. So what else are we missing when we're trying to count everything? What's the blind spot here when we are so obsessed with data?
I would really bring that back to your point earlier about who's picking what to count as well. You know, the stuff about the homogeneity of the designers, like how much are we missing because of that homogeneity? You know, I got real problems with the idea of a technology future that's built by 20 or 30-year-old white men. Like, that's got problems for me. And as a 20 to 30-year-old white male, like, that scares the bejeebers out of me.
Anyone else have anything to add?
I think it is a really big challenge in a whole range of different areas, because a lot of people are interested in the health data of people living in low and middle income countries. And we've seen it in a number of instances of particularly retinal images, which are very rich in data around chronic disease, and there's a lot of people being very interested in those. They also have a real very clear personal identification of each person, and that throws up a whole lot of risks for people and for health professionals. So I think that's one of the challenges of collecting big data, that you put actually people at risk, and the moral question is to say that actually you might not need them to put in. You can actually source that using big data to actually make a broader generalisation, because you've got a much bigger cohort than what you might have had previously.
Yeah, and one other thing I would say, like, I think when you embed yourself in a certain kind of worldview, that ends up affecting the way that you perceive everything. And for instance, like, speaking personally, I can tell you that, like, in some of the coding projects that I've worked on over the years, where I've gotten really, really deep into a program over the course of several months, I find my perception of reality starting to become like a database. And I start to see my human relationships as bugs that can be decoded and fixed if only I could find the root of the problem. And when people act in unexpected ways, I get really upset because it doesn't match the mental model of the system that had been in my mind. And this is a very dangerous way to behave as a human, but it's a way that's very easy to behave when you've embedded yourself in that kind of worldview. And so I would just offer a cautionary note, like, as we're all surrendering so much over to this cult of big data, how is it affecting our capacity to be a good partner, a good son, a good spouse, a good parent, a good friend? Is it actually helpful in those, or is it having an effect on our human relationships? Just a question. I don't know. We could each ask ourselves that.
So we've been told a couple of times throughout the morning to go and break the rules. So I'm just going to go and do that right now and actually go out to the floor. So roving mic in hand, does anyone have a question they'd like to put out to this panel? Don't all jump at once. Oh, hang on. I got it.
I wanted to ask whether you have any way of controlling the use of useless tests and ineffective or even dangerous treatments. I mean, there's a big move which started in the States to try and get some control, and there are organisations that have defined that, within obstetrics or within orthopaedics, the following procedures actually are either useless or even dangerous. I mean, I don't know how many people realise that. You should be really careful about the doctors you go to.
I'm actually happy you mentioned that. So that was when I interviewed at Oscar years ago, they said, why do you want to join? And this is very similar. It's a similar problem, but a different component of it. I said one of the biggest problems that I want to see fixed in US healthcare is the pharmaceutical side of things. And the reason why is you have a really bad drug that hits the market, and the way that you detect that drug is having bad symptoms is they rely on the doctors to report that information back up to the pharmaceutical company. Now, how that works is the pharmaceutical company will say, great, this doctor has a case here. They send someone out and they investigate to find out how that doctor administered the drug incorrectly. And so there's no positive incentive as to detecting when that drug's being harmful. What I loved about being an insurance company that has access to all this data is you can see that this doctor prescribed drug A, and then 2 weeks later, drug B. And then you can see that pattern over and over again. And very similar to bad procedures and bad operations, where you see additional follow-ups that are needed, you can see those patterns, you can start identifying that stuff much sooner. And that's kind of the beauty of being the insurance company, is you are in the center of all that flow of data. And that's a powerful place to be. If you use it to make money, that's bad. If you're using it to really improve people's health, which is what we're shooting to do, then it's a pretty awesome power to have access to.
And certainly that's an issue for government as a payer. And at the moment, people may be aware there's a review, for example, of the medical benefit schedule and so on. And one of the issues there is looking at stuff that's already been in the press around are we overdoing colonoscopies and arthroscopies and a range of these services. It comes down to incentives. At the end of the day, you change behaviour by changing incentives. In healthcare, that's often the dollars associated with things. We're very poor at giving positive incentives for good. One of the issues in Australia is around, you talked about, telehealth services and e-health services. There's no MBS item that lets you get a repeat prescription from your doctor. So you've got to go and visit them and pay, $38 for a visit for something that if it's not something that he has to do a review for you for, he could have just done over the phone or sent you an email about. So, it's also about those sorts of incentives as well. Healthcare is unsustainably affordable. Even in Australia and the US, it's double our costs. We have to look at smarter ways of doing that. That's going to come down to looking at what we do now and what's better practice. In terms of data, I agree with the issue. It's not about big data, it's about little data. It's about looking at what happens. At the moment, our system is very focused on what happens in each episode. What happens when you're in hospital? What happens when you go to GP? What happens when you go to community? We should be looking at what happens to you as an individual. How do we deal with you across your lifetime? How do we resource that? How do we analyse that? It's difficult, but technology can do it.
Also, something that's kind of cool is when we started, we took 80,000 doctors and we questioned. We said, all right, if I spend more money on my healthcare, does that mean I'm actually going to get better health, better care for my price or my money? And if that was true, if you graph that, you'd see a nice even distribution of money spent and care coming back. What you ended up seeing was just a scattered chaos everywhere. What that tells us is doctors were just charging whatever they wanted for all these different procedures. They were giving all these extra tests you don't need. So we just kind of drew the line in the sand. We said, look, this is how much this procedure costs. If you're going to charge more, then we don't want you in our network. If you are giving all these extra tests you don't need, you're not in our network. So there's a real incentive then to be a good doctor and provide the right care at the right price. And that's where you start kind of getting some power back in this healthcare system.
Can I ask a bit of a follow-up question to the panel? And this is definitely from the I don't know anything about health thing. How do you get individuals to really care and own their own healthcare? Because I feel like a lot of the conversation we've had is the way that systems, be they doctors, insurance companies, whatever it might be, are about optimizing the healthcare experience for the customer kind of thing. How do you change that around and get people to actually give a shit about their own healthcare?
Two of our co-founders started a very successful, actually it was the largest mobile gaming service or company in South America. And why that's important is they're all about gamification and behavior and incentives. Imagine the South American version of Farmville. And the original version of Oscar was you kind of wanted a Farmville for your health insurance. You want to get people addicted to checking in on your health, logging into your health care's website, finding out how you're doing, your performances, and earning rewards for having good behavior. And so, sure, we don't have coins and things you're mining on your site, but you can see those incentives kind of appearing in more elegant ways now. And that's kind of the root of Oscar from years ago.
The CSIRO Health and Wellbeing site, if you go to it, you can pay $150 and you sign up for 3 months for this, and every day you have to log what your weight is and what your exercise you're doing, and it sends you all this motivational stuff, and at the end of, if you meet your target at the end of it, you can claim your $150 off the health insurer.
Megan.
I think it's a really tricky question, and it comes back to what you value yourself, and we each have different values and make really distinct choices of not getting around your checkup and things like that, even though we've got all the knowledge that we know that that's what we should be doing. From some of the work that Fred Hollows has been doing, we've actually been looking at, because we're all about eye health, about how we can actually motivate people to look after their eyes when they've got diabetes. And one of the things that we've been testing is that it's a really powerful motivator for people with diabetes to actually see an image of their eyes and how that's actually deteriorating, and that eventually they will lose their sight. So that's something that they can't see, but they need to have an image of, and they can actually see that that's something invisible happening within them. That's not for everybody, but if we can find a whole range of different things that are able to change behaviour and able to apply each of those, we can actually make or kick off that behaviour change that makes a difference in somebody managing their own health.
Kelsey?
Oh, sorry. So there's a lot of new procedures that are coming out, particularly in the cancer space, like photon therapy, which actually require a proton cannon at some kind of big long canon thing, to actually to deliver. And it's really expensive, but it's really, really effective as composed to radiotherapy for kids with tumors and things like that. I think we've talked a lot today about driving to low cost and really effective care in developing nations and things like that. But where do these high cost, or where do these really technological advances come into play when we're balancing outcomes versus cost? Sorry, does that make sense to the question? And so it's like, if we've got this amazing new technology here, it's much more effective at treating cancer, and you're more targeted, and your life and well-being is better afterwards, but it's really, really, really expensive. Do we have a responsibility to deliver that in a more cost-effective way, if that's possible, or do we only focus on finding new care that is actually low cost? Sorry.
Can I start? I'm going to start, because I don't know anything about health, I'm going to answer it with spaceships. So NASA, I think, are really the example I would look to for that. The first bit of Velcro would have cost like $1 bajillion million, right? Because it didn't exist yet. But now that it exists, and it went through commercialization, and it went through all the other processes that technology goes through, now you go to the local supermarket and buy it for $1. So I think absolutely we should look to those things and look to support them and grow them, and not believe that tomorrow they're going to be in low resource environments. But we should still back them, because over a period of time, hopefully they get that cost reduced, they get that accessibility gain, they get all those kinds of things that will improve in both high and low cost environments. I think there's a really important responsibility on the health sector and the research sector to not just go and find the most amazing new technology, but also follow that through with, okay, now how are we going to make this accessible to the wider community? But you do have to start at that kind of NASA level stuff first.
Well said.
Anyone else want to add to that, or was that a mic drop moment? Apparently. So one of the questions that came in on the line are, what are some of the quote-unquote cool things happening in the tech space that don't directly impact health, but instead it's social determinants, and how is this applied to low resource settings, e.g. in housing, sanitation and education? Would you like me to repeat that one? Yeah, can you say it again? So what are some of the cool things happening in the tech space that don't directly impact health, but instead it's social determinants?
One of the coolest companies I saw, it's started by one of the co-founders of Facebook. It's called Segovia out of New York City. Their mission is to build a delivery network through all these remote regions. So you think about trying to get whatever it is you want delivered out to these villages. These are villages that don't have any streets, there's no numbers on houses, and they're building that network. So you can start getting medicine in there, you can start getting all sorts of things delivered. And I think that's really pretty awesome and a really challenging problem. So I think it's Segovia, S-E-G-O-V-I-A, definitely worth looking into.
Not so much a technology thing, but the issue was raised earlier. I was asked once what I thought was the best long-term investment in health care for the country, and I said Gonski, because if you look at the correlation between educational levels and health outcomes, it's stronger than just about anything you could possibly consider. So things that are supporting general literacy and understanding of yourself as a self and the opportunities that you have there, I think is an enormous opportunity.
My example of that would be the One Girl Project by Chantel Baxter. She's amazing, and all the work that they do is absolutely amazing, and it's totally that. It's just getting better health stuff through education. Great. Yep.
I think not so much about health or anything like that. I think the one thing that's very exciting that we're seeing more of is people releasing their intellectual property into the public domain for public good. I think that across a whole range of areas is one of the most exciting things.
Jonathan, anything? All right. So I think, well, in the interest of our time, I would like to ask one final question, and we'll start with you. So, and you can take a second to think about this, but if you had one wish for 2016 and one alone about improving health outcomes in low resource settings with technology, from whatever background you have, one wish, what would it be? If it was sitting on this panel in 12 months and you could look back and go, that was a pretty good year, how do we get to that point?
I think I'd like to see people learn to take control over their own attention and realize what a precious resource that is, and that we each have the same amount of it, and that that's really the same as your life, because it's what's happening from moment to moment. So realizing that and doing whatever exercises are necessary to learn to master your attention.
If the FreeO2 people are here in the audience, I hope that their project is funded. They're doing a really cool project, which is, people die of pneumonia all the time. It takes oxygen to cure it. They are building oxygen compressors that don't rely on electricity. So you can just stick them in a river and it'll run off water power and provide oxygen back to people who need it. You think about how many people die under the age of 5 with that condition that's so easily curable. So their project's pretty awesome. So I see them there. I hope you guys get the funding you deserve.
The comment was made before, it's all about getting access to the data. I would hope that many more people, organisations, make their data accessible through open APIs that people can use to inform any number of applications and supporting them around there, because at the moment, that information's so locked up. I had a meeting with the Swedish Minister for Health last week, and in Sweden they have over 100 patient-consented repositories targeted at particular conditions or services. They're analysing to death to try and find out what works better. I thought, how fabulous if we could encourage more of that sort of thing happening.
I feel really unable to answer this question in low resource and health, but so my contribution is going to be, I love Bill Gates and I love XKCD, and recently they did a comic kind of together, which was about eradicating polio, and you don't need a wearable, you don't need a new widget, you don't need a new toy, you don't need a strategy, we just need to keep doing the same thing we've been doing for the last however long it's been, and let's just knock that one out of the park. That would be pretty awesome.
I think that's a difficult one to follow. Sorry. I think if we, I think this is ambitious, probably not going to happen in 2016, but I think I'd like policy or human-made policy problems that sort of impact the health of future generations to actually be thought through, and I think one of the examples is with a really big concentration on the MDGs and childhood mortality rates. A lot of incubators have been set up in rural hospitals where people really aren't trained to actually look after them. So we're seeing a lot of newborns who've had oxygen applied, and so they're now blind. So it's a small problem, but it's a man-made one, and I'd like to, that'd be my wish for 2016.
Thank you very much. So I'd like to ask you all to thank our panellists.